Hello, everyone. Okay, now let's get started with ENT otology. Here, it's a very simple thing. I mean, if you understand things, it's going to be a simple session. All right, let's talk about auditory anatomy and physiology. Very high yield. So, what we have here, if you take a look at this image here, it's about the nerve supply to the external ear. Okay, so let's just take a look. So, we have the upper part supplied by the lesser occipital nerve. The medial part of the upper part is supplied by the V3, which is called auriculotemporal branch. Facial nerve, if you take a look, it supplies the very inner part as the facial sensory branch. Vagus nerve also supplies, again, the inner part. And then you have this greater auricular nerve, which supplies the lower part of the lobe. Now, importantly, why is this important? Well, it is important because one of the things that you would clinically see is that if you, when you have an examination of the external ear, right? In the examination of the external ear, uh, the otoscope, the otoscope goes in this place, right? And it can stimulate the vagus nerve. And when it would stimulate the vagus nerve, the patient can go into vasovagal syncope. Okay. And what is that going to be like? For example, decrease in heart rate right away and decrease in blood pressure. So, okay, that's a clinical significance for the vagus nerve. Again, what I talked about is this vagus nerve in the external ear examination. The otoscope, uh, the part of otoscope goes into the ear, right? And that would stimulate this nerve, vagus nerve, and that is going to cause vasovagal syncope, and that is the only clinical significance here, nothing else. And then next you have, so this is all about external ear. Now just take a look at middle ear. Middle ear, let me erase this. In the middle ear, what we have is we have the tympanic membrane, we have the ossicles, and in the last inner ear, internal ear, we have all the rest of the things, and which we will talk about here. So let's take a look here. So outer ear is visible portion of the ear, which is pinna, includes auditory canal, the tympanic membrane, and transverse sound waves via vibration of the tympanic membrane. Remember the keyword vibration here. Middle ear is an air fluid space with three bones called ossicles. What are the ossicles? Malleus, incus, and stapes. Ossicles conduct and amplify sound from tympanic membrane to the inner ear. So these guys, they amplify sound. Inner ear, it's a snail-shaped, we'll take a look at the picture, but here the inner ear is a snail-shaped fluid-filled cochlea. It contains basilar membrane, important, that vibrates a secondary sound, secondary to sound waves. Vibration transduced via specialized hair cells lead to auditory nerve signaling, which goes to the brainstem, and then you perceive the sound or the language or whatever the sound is, right? So each frequency leads to vibration of a specific location on the basilar membrane, tonotropy. Low frequencies heard at the apex near the helicotrema, which is a wide and flexible. High frequencies are heard best at the base of the cochlea. So what is this helicotrema? Let's just draw a couple things here. So let's just take a look here. Where should I draw here? Okay, so let's just maybe think about it. This is as a cross section of this point. So all we have is, we have sort of this. Okay, so here we have two membranes. This membrane is called as Reisner's membrane. This one is the one we talked about, which is the basilar membrane. Now, importantly, these are the membrane, but what are the structures? Now, this structure is the scala vestibuli. I'm just going to write SV. And this structure is going to be the scala tympani. Now, scala vestibuli is going to contain some fluid known as perilymph. The scala tympani is also going to contain some fluid, also known as perilymph. So they both have same fluid. Now, importantly, what is going to be different is going to be this part in the middle, and this part is cochlear duct. And this contains endolymph. Okay, and it is also known as this cochlear duct is also known as scala. Let me just go back to my color here. Scala media, also known as cochlear duct. Okay, now in the cochlear duct or scala media, we have organ of Corti. Here's the organ of Corti. Organ of Corti. Okay, and that's, let's just erase some extra stuff that I have here so we can really take a look at what are we talking about, right? Okay, here. So yeah, here we have the proper structure. Now, just to do in this sort of scenario that you understand what I wrote there is all about. Here you have this. So you have an ossicle known as stapes. I'm just going to write how the sound is transmitted, which is mentioned here. So the sound is transmitted from stapes, so tympanic membrane, stapes, to where? Now the question arises, where does the sound go in first place? So it has to go through oval window. First is oval window. And then from oval window, there's a full scala, as we mentioned, scala vestibuli, that is there. And that would turn. That turn is called helicotrema. Okay, so this turn is the helicotrema. Okay, and that's going to open into another window that is called round window. Okay, round window. And that is going to be called as, if this is scala vestibuli, this is going to be scala tympani. Okay, and they both contain perilymph because the fluid is just going all the way through this part, right? Just the middle part is different. This part, it is the scala media, which we mentioned right up there. And that contained the endolymph. And why is that important is going to come up later, that why endolymph is important. But just to understand the anatomy, full-on anatomy here, this is going to be the inner ear structures. So, yep, then that's going to be all. So let's just take a look at the inner ear here picture. So we have the tympanic membrane that's going to hit on with our ossicles, and those ossicles are hitting on the oval window. Through oval window, we said we have the scala vestibuli that is going all the way, and it's opening into the round window, which I guess is not mentioned there, and that would eventually will go into the cranial nerves, cranial nerve 8. But let's just take a look at important things here. High yield important low frequencies are the apex. What are they heard at low frequencies? Are heard at the apex of helicotrema. Here's the helicotrema. They're heard there. What about the high frequencies? High frequencies are heard best at the base of the cochlea, so base of the cochlea. Okay, moving on with the actual pathology here, which is otitis externa. As the name suggests, externa, right? External ear. So there's an inflammation of the external auditory canal, most commonly due to Pseudomonas high yield, associated with water exposure, swimmer's ear, ear canal, trauma, occlusion, example, hearing aid. It's going to present with, a patient is going to present with otalgia that worsens with ear manipulations. You can't touch the ear. It's painful. Pruritus is there. Hearing loss, discharge, as you can see in the picture. Then with the external otitis externa, you get something called malignant necrotizing otitis externa. As the name suggests, it's a malignant necrotizing externa, right? So it is invasive infection causing osteomyelitis. Complications of otitis externa, mostly seen in older patients with diabetes, present with severe otalgia, anorexia, may lead to cranial nerve palsies. Physical examination shows granulation tissue in the ear canal. So if you see granulation, or if you see something, a old patient who is diabetic and has prolonged otitis externa, you're going to think about malignant necrotizing otitis externa. Okay. Now let's take a look at the next one. We have here otitis media. Now we're from external ear. Now we're looking at the middle ear, media. Here's the middle ear. Okay, so here what we have is the inflammation of the middle ear. Yeah, most commonly due to non-typable step pneumonia. Important, but bugs are important. Okay, so again, non-typable step pneumonia, Haemophilus influenza, Moraxella catarrhalis, associated with eustachian tube dysfunction. That is the association. Eustachian tube dysfunction. If you just take a look at this picture up top, the eustachian tube, haven't they mentioned it here? Here. Let me just erase this part. Eustachian tube is coming here and opening all the way in the inner ear and also in the middle ear. So if you have a blockade of eustachian tube, that's going to promote the overgrowth of bacterial colonization of the upper respiratory tract, right? So there is an overgrowth of the bacterial colonizers of the upper respiratory tract, which are going to be up top all of these. And then you have the usually seen in less than 2 years of age, presents with fever. If you recall, externa did not have any fever. Otalgia is there. Hearing loss, same thing. They also had a hearing loss. They had otalgia. Physical examination shows bulging, important. Bulging erythematous tympanic membrane. Look at picture A. First of all, you're going to see bulging erythematous redness of the tympanic membrane. Okay. And that may rupture. The complication here is mastoiditis, which is infection of the mastoid process of the temporal bone. Complication of acute otitis media. Complication of acute. So acutely, when you had this media, it can go into mastoiditis as a complication, and which is basically a infection of the mastoid process of the temporal bone. And why this happened? Due to continuity of the middle ear cavity with mastoid ear cells. So middle ear has mastoid ear cells, which get the infection called mastoiditis. Simple. It's going to present with post-auricular pain, high yield. So post-auricular pain is there. Erythema, swelling is there. May lead to brain abscess, high yield. Okay, let's just review this page and move on to the next page. Here, all we talked about, importantly, is a couple features. Let's just go through them. The first thing we said that we have the vagus nerve, which also supplies part of this not inner ear, but part of the external ear. So if you, when you're trying to see the ear, the otoscope might stimulate it enough that it can lead to vasovagal syncope, and that is going to cause decrease in heart rate, decrease in blood pressure in a patient. Okay, that's one thing clinically tie-in, right? The other thing we talked about here is all important membrane. So we have we have the scala vestibuli. Here we have scala tympani. And these membranes, we have Reasoner membranes for the scala vestibuli. We have basilar membrane for the scala tympani. And in between these, we have scala media, which is also known as cochlear duct. That's the one which has the endolymph, and the rest of the both have the perilymph because they're connected to each other. And that connection, that turn, is called helicotrema. Okay. We have oval window in which from the tympanic, the ossicles hit on the oval window, and then we have this round window, which is the total end on the other side. Okay. Outer ear is all about, it's going to send the waves, vibration to the tympanic membrane. Middle ear, it will amplify sound conducted through the ossicles to the inner ear. Inner ear, it has a fluid film. What are two fluids it has? It has a perilymph and an endolymph. A basilar membrane that vibrates secondary to sound waves. So this basilar membrane we talked about here, it's going to vibrate it. And now we will read next that it has hair cells, and that tectorial membrane is going to shift, but we will talk about that. But just remember at this point, basilar membrane is there, which vibrates secondary to sound waves. Now those sound waves, when these vibrations, they are transduced via hair cells, and that hair cells is going to send the auditory nerve signaling to the brain stem, which we will perceive as sound. Okay, this is the whole thing about hearing. Now, frequencies are different. They hit different sections. They are specific frequencies or specific location on the basilar membrane. Specific location on the basilar membrane. Okay, low frequency is gonna best heard at near the helicotrema, at the apex near the helicotrema, which is wide and flexible, while the high frequencies are best heard at the base of the cochlea. Okay, so just to go back to the mnemonic that we just thought about, I just thought about, but if you guys have any good mnemonic, that'd be great. I'm happy to hear that. But here's the low molecular weight heparin, low for low frequencies, and H for helicotrema. So the low frequencies are going to hit the helicotrema, and the rest is just cochlea. That's just one of the things that we can think of. But the next here we have, let me erase this part. Okay, we have the otitis externa. Pretty easy. Otitis externa is all about Pseudomonas is the most common cause, and otalgia with pruritus, hearing loss, discharge. But importantly, that it can cause necrotizing something. What is? It's an invasive infection with the osteomyelitis, and you are there is in all patients, specifically with diabetes, they can go into this necrotizing otitis externa. That can also lead to cranial palsies and high yield. You will see granulation tissue in the ear canal. You see granulation tissue, you're going to think of the malignant necrotizing otitis externa. Lastly, we have media, otitis media. It's all about non-typable step pneumonia. Look at all the upper respiratory tract bugs. Strep pneumonia, Haemophilus influenza, Moraxella, Carteralis. Why? Because they travel through the, there's overgrowth due to the eustachian tube blockade or dysfunction, and that just goes back into the middle ear and cause infection. They're usually seen in less than 2 years of age. And fever is there, high yield, hearing loss, bulging erythematous tympanic, high yield fever, bulging erythematous tympanic membrane. Okay. Otitis media can go into mastoiditis, which is again the mastoid ear cells, which are the continuity of the middle ear cavity with the mastoid cell. So this infection just goes and travels to the mastoid ear cell, causing mastoiditis, which is going to be seen as post-auricle pain, erythema swelling, and also can lead to brain abscess. Okay, now we're going to talk about is called common causes of hearing loss. So we have noise-induced hearing loss and presbycusis. Now noise-induced hearing loss is damage to the stereociliated cells in the organ of Corti. And if you recall, we did talk about organ Corti being at the very center right here, right? So here all we have is damage to the stereociliated cells in the organ of Corti, leads to loss of high frequencies hearing first, would lead to sudden extremely loud noises can produce hearing loss due to tympanic membrane rupture. So a patient represented, okay, whenever they have an extreme loud sound or loud noises, they go into hearing loss. Now, and that can be because of the tympanic membrane rupture. Okay, so just remember this thing for this point is that you have prolonged exposure to loud noises, and that is just going to damage the organ of Corti, and you will lose to high frequencies first. Because if you, let me just mention one last point for this point here. So if you recall the organ of Corti, it's the cilia cells, right? It's the cilia of hair cells that keep on hitting the tectorial membrane. Tectorial membrane. This leads to damage to the cilia. And when you keep on hitting the tectorial membrane, because it's a very prolonged exposure to those loud noises, that the hair cells keep on hitting this tectorial membrane, that's going to cause damage to the cilia, and that's going to cause hearing loss. Now you might ask, where's this tectorial membrane? So the tectorial membrane is, if you, let me just draw it quickly. So let's just draw it here. So we have these hair cells, right? And these hair cells, they have the cilia up top. And up top, we have this membrane known as tectorial membrane. And when these cilias, so actually, let's talk about a full thing, how, because I mean, if I even talk about it, you would not understand what I'm saying here. So let's just talk about how the whole sound is being, how is it perceived and how does it transmit and everything, right? So let's just talk about it where. Limited space. Amazing. Let's just talk here. So here is all we're going to talk about normal, how everything is perceived normally. So we have the transduction. We have the transduction of the mechanical sound waves, right, into the nerve impulses. That's the whole point. And question is how? How we have the sound goes into the nerve impulses, and how does this transduction occur, right? So let's talk about the first thing. So sound reaches the middle ear, as we talked about. Sound would reach the middle ear by the vibration of the tympanic membranes. You vibrated the tympanic membrane, that causes the vibration of these stapes, or you can just call ossicles. And those ossicles are going to vibrate where we talked about it, oval window. Let's just write oval window by the ossicles, right? Now, when you stimulate the oval window, that oval window will cause vibration of the basilar membrane. Let's just write B, basilar membrane. And if you know, basilar membrane is all about the part that has the scala vestibuli, right? But just remember here, basilar membrane, simple thing. Basilar membrane. Now this causes bending of the hair cells, bending of hair cells, and hair cell cilia. So hair cells, as I mentioned up top, that I'll draw this again, but just to go through the whole concept here. First we talk about it, then I'll draw it. The hair cell has cilia that causes oscillations. The cilia is going to oscillate. Oscillation movement here is going to happen. Oscillation is going to happen. And that oscillation is going to cause two things. Either it's going to cause hyperpolarization or depolarization. Actually, depolarization and hyperpolarization of the auditory nerve. And this creates impulse that we perceive as sound, that would form the sound. Okay, so that is what we have now. I hope you understand the whole thing, but again, let me just go through it quickly. So we have the stimulation of tympanic membrane. We all know that part, but what we do not know, I mean, we know already, but it's just a recall. Tympanic membrane is going to stimulate the stapes. That's going to stimulate the oval window, and that will stimulate the basilar membrane. When you stimulate the basilar membrane, that you are going to cause the bending of the hair cell cilia. For example, as I mentioned right here, this is the hair cells. We have cilia up top. When we are going to stimulate this basilar membrane, it's going to stimulate these hair cells, and these hair cells have their cilia up top. So cilia will also go into oscillation and they will move. When they move, there's a tectorial membrane which also moves according to it. That leads to depolarization. Where did it go? Here. It leads to oscillation. I mean, cilia oscillates, leads to hyperpolarization and depolarization of auditory nerve. And that is going to create an impulse that is going to form the sound. That's the whole thing. So now here, the noise-induced hearing loss, we said that the cilia of the hair cells, are going to keep hitting on this tectorial membrane. And then when you keep hitting on this tectorial membrane, you're eventually going to damage the cilia itself. And that is going to lead to hearing loss. Now, no matter how much sound is going to come in, now the cilia, you have destroyed the cilia, so no cilia is going to move. When the no cilia oscillation is not going to happen, you will not move the tectorial membrane. You will not get the hyperpolarization and depolarization of the auditory nerve, and that's going to lead to no conduction, no sound perceived, right? So that's the whole thing about noise-induced hearing loss. Prolonged hair sound. Let's just remove this, and now let's review this part. Prolonged hair cells damage the organ of Corey, causes high frequencies loss first, because again, low frequencies, as somebody had a very great mnemonic about the helicotrema. Helicopters fly low, so helicotrema, low frequencies. So that's why we are just losing here the high frequencies, the max, which is the first thing we can lose. Then you also have a sudden extreme loud noise can produce hearing loss due to tympanic membrane rupture. Okay, very tangent detailed here. But next we have this presbycusis. This is aging-related progressive, bilateral, symmetrical, sensory neural hearing loss, which is often of the higher frequencies due to destruction of the hair cells at the cochlear base. So they were saying again, the base is affected, so the apex is preserved, so low frequency is going to be preserved. So if you think about these two things, all you can remember, okay, the high frequencies are going to be affected the most. Okay, on top of it, that's what you're going to think about. Hearing loss, is it a noise-induced or a presbycusis? You're going to think about either age or either prolonged loud noise exposure. Both will have a high frequency. One of the mnemonics you can think about, loud noise means high noise. Aging, high age. So both will have high frequencies being affected. Okay. And that is what we are going to see with this. The next we have here is the proper diagnosing of the hearing loss. So let's just talk about that part. Let me erase all this. So it's very easy. Just understand a couple things here. All we have is two tests, Weber's and Riney's. So the Weber, how we do Weber is we have a tuning fork. We put the tuning fork. We first of all we stimulate the tuning fork, and then we put it on the vertex of the skull. This is the vertex, the mid part. Excuse me, the mid part of the skull, vortex of skull. Okay, and normally there is no localization, meaning both ears are gonna hear the same thing. Okay, and that is normal. Now, in conductive hearing, first of all, let's talk about what is conductive hearing loss. Well, conductive hearing loss is for any disease. Where is it? Give me 1 second. Okay, here. Any disease that would interfere with conduction, right, of sound from external ear to the inner ear, external ear to all the way towards the inner ear. Anything that would, block this conduction is called conductive hearing loss. And what about sensory neural hearing? As the name suggests, sensory neural hearing loss. It is due to the damage to either the cochlea, either you're damaging the cochlea, which leads to a sensory type of sensory neural hearing loss, or you're damaging the nerve, which is the cranial nerve 8, CN8. Right, and that would cause a neural type, as the name says, sensory cochlear damage, neural type, cranial nerve 8 damage. Okay, and that's the definition. Now let's get back here. In Weber's test, what we have is with the conductive hearing lossless, right here. So what we're going to do is we have this tuning fork, we stimulate it, put it on the vertex. Now it's going to lateralize towards the affected ear. So it localizes to the affected ear. So you already know this, if ear is affected, they can't hear the sound here. And when you put the tuning fork, those vibrations are going towards, they're localizing to the affected ear. Okay. And there's a decreased transmission of the background noise with the conductive hearing loss. So, and a question is, why is that? Because as the conduction deficit masks the ambient noise in the room, which allows the vibration to be better heard, so you will have this decrease in the transmission of the background noise. The next is about sensory neural hearing loss. Sensory neural hearing loss. Here, what we have is that it is going to be opposite of this. So it's just a mnemonic, it's an opposite, but what it is, it's basically localizing to unaffected ear. Here it was localizing to the affected ear, but here we have the unaffected ear. And there's a decreased transmission of all sounds. Okay, so let me take a step back and talk about the whole thing again. So what we talked about is a Weber test. Again, Weber test, when we place the vibrating tuning fork on the middle of the forehead or the vertex, right? And normally what's happening is the vibrations are going both sides equal. That's normal. But if they lateralize to the affected ear, then that is called conductive hearing loss. And if they lateralize to the unaffected ear, that's going to be sensory neural hearing loss. Okay. That's all about the Weber's test. Now let's take a look at Riney test. Riney test, again, tuning fork is fork in front of ear. So we do place it in front, but first we place it on the mastoid processes. So let's just take a look. First, what we do is we have a tuning fork on the mastoid process to see the bone conduction. And as soon as they stop hearing from the bone conduction, we move this all the way to the ear and say, hey, can you hear this? And that's the ear conduction. Normally, what we have is, here's the normal, right? Normal is AC, which is ear conduction, is better, is more than the bone conduction. So that is normal. So we call it, when we have a normal test, here we call it Rini positive. Rini positive. Okay, and when we have an abnormal test, we call it Rini negative. What is Rini positive? Rini positive basically means, okay, we have air conduction, which is better or which is greater than the bone conduction. Okay, that's the whole just a normal thing here, right? So now let's talk about what's going to happen in conductive and what's going to happen in sensorineural hearing loss. So in conductive hearing loss, what we are going to get with Rini test is that it's going to, the bone, look at this, the bone conduction is greater than the air conduction. And in the sensorineural hearing losses, of course, it's going to be sort of simple as positive, which is total normal. Look, if air conduction is greater than the bone conduction, but we are going through sensorineural hearing loss. Again, if you recall what I talked about, the definition part is very important. The conduction is all about the conduction, meaning from external ear all the way to internal ear, there is some blockade, conduction problem. While the sensorineural hearing loss is about not the conduction problem, but the inner part problem, meaning either the cochlea or either the cranial nerve 8, CN8, right? So that's the sensorineural hearing loss. So here, because when we deal with sensorineural hearing loss, there is no conduction problem. When we don't have any conduction problem, so everything is going to be as if the Rini is positive, which is total normal. Then what we do is we then go for the Weber's test to really actually see if it's sensorineural hearing loss. So let me just revise this now in a simplistic wording, the Rini test. So Rini test, what we do is we have, it basically compares the air conduction and the bone conduction versus bone conduction. And how are we checking the bone conduction? And that is to this mastoid bone. Okay. Now what we do is we take this tuning fork, when we stimulate it, it leads to vibration, and that vibrating tuning fork, we put it on the mastoid. First, what we do, we put it on the mastoid process. When we put it on the mastoid process, and then now when they stop hearing from the bone, not hearing, but that vibration, they stop the hearing from it, we bring it close to the ear and say, can you still hear that vibration sound? Okay. And if the patient hears the sound, at this point, we call it, okay, they have air conduction greater than bone conduction, because bone conduction, they stopped hearing at this point, right? That is when we moved here. So we call it is air conduction greater than bone conduction. So Rini positive, which is total normal. It's a normal thing. It's a normal individual. Okay. Now just take a look at the conductive. But if they cannot hear the sound when you bring it here, if they cannot hear the sound, then we call it, okay, the bone conduction is greater than the air conduction. It means that there is a conduction problem, conductive hearing loss, and we call it Rini negative. Okay, and that is what we have. And conduction problem, again, it's going to be something blockade, for example. Let me write here the examples. For example, you have external ear obstruction. For example, you have the tympanic membrane perforation, middle ear fluid being there, ossicle fixation, eustachian tube blockade. All of these are the conduction problems. Okay. Now, one last thing for this point, that if you look at these two, they're pretty much the same, but here conduction is air conduction greater than bone conduction, but bilaterally both of them going to be decreased. For example, if the normal individual is going to hear the sound for, let's say, 30 seconds, right? These sensorineural, I mean, this is just it might not, it's just a concept, okay, not to worry about it much. But what we have is AC will be greater than BC, but both are going to be reduced bilaterally, meaning a normal patient can hear this sound for 30 seconds. With the sensorineural hearing loss, they can only hear it for 20 seconds. But again, the Rini is going to be positive, which is normal because air conduction is going to be greater. So again, when they were hearing from the bone, when they stopped hearing, you moved to the ear, they're still hearing from the ear. So that's total normal. But the duration is decreased, and that's called reduced bilaterally. But that's not mentioned here, so forget that part. And that's going to be all for these two tests. One of the extra thing which isn't mentioned here is called cochlear implant. Cochlear implant. Cochlear implants. Cochlear implants through its electrode directly. So they will ask you, okay, cochlear implant, how is it going to stimulate, or how is it helpful? Well, it's going to directly stimulate the auditory nerve. So treatment cochlear implant is directly stimulating the auditory nerve, and that is important. Okay, and that is all for this one. Let's move on to the next part, which is cholesteatoma. Cholesteatoma, right? It is abnormal growth of keratinized squamous epithelium in the middle ear, which is skin in the wrong place. Just think about it, skin in the wrong place. Is usually acquired, but can be congenital. Primary acquired results from tympanic membrane retraction. Again, the primary due to tympanic membrane being retracted. So when you retract the tympanic membrane, it's going to cause pocket formation due to eustachian tube. The pockets will form due to eustachian tube dysfunction. Secondary acquired results from tympanic membrane perforation. So perforation, retraction, perforation, two things. It is example due to otitis media that permits the migration. When you perforate it, it's an open area. It's an opening, so that the squamous cell will the squamous epithelium would migrate to the middle ear, and that will cause skin in the wrong place and keratinization squamous epithelium being abnormal growth. Classically, is going to present with painless otorrhea. They have otorrhea, but there is painless. There's no pain. Okay, and it might erode the ossicles. And when it erodes the ossicle, it's going to lead to, again, conduction problem. So conductive hearing loss. Okay. And that is what we have here. If you look at this picture here, all we have is we can see this. We can see a mass. So how it's going to present is going to be actually, they'll say purely mass behind the tympanic membrane. Mass behind tympanic membrane, Okay. And it is, again, what is important, it is the collection of squamous cell debris or abnormal keratinized squamous epithelium. Okay, but this is also very important, the mass behind the tympanic membrane. Okay, now the question might arise that why is it called cholesteatoma? It's not actually, I mean, just think about it. It's not lipid or anything, but still it's called cholesteatoma because eventually, I mean, first they thought about it as a lipid, but it wasn't lipid. Then they figured out it's just a skin. So all they have is, let's just talk about the quickly. When we talked about the acquired primary lesion is due to membrane retraction. That membrane retraction is going to cause negative pressure being built up in the middle ear. Okay, and that is going to cause the dysfunction of the eustachian tube. Okay, and this negative pressure would actually suck into the tympanic membrane, causing retraction of that tympanic membrane. Tympanic membrane, leading to formation of pockets, and in these pockets that can become cystic. These pockets can become cystic, and squamous cell debris would accumulate there, and leading to formation of this cholesteatoma. Secondary acquired lesion. Let me just erase this part. Secondary acquired lesion is due to, again, chronic repeated infections. All they're talking about here is perforation, but other than this, secondary acquired can also be due to due to chronic repeated infections, or surgery, or trauma, or infection. Infection is there. and repeated trauma. Trauma and repeated infections. And with all of these risk factors, not risk factor, but predisposing factors, what's going to happen is that uh, it's going to cause keratinization, which causes squamous epithelial lines formation, and that causes skin in the wrong place. The reticulocytoma. Complications of these are, as you talked about, is going to be when you roll the ossicles, you are going to get conductive hearing loss, but on top of that, you have a couple more. So let's just talk about some complications here. The complications are that it can erode ossicles, leading to conductive hearing loss. Second thing is it can go into the mastoid hair cells, and that it can erode the mastoid hair cells. It can also go and infiltrate this vestibular apparatus. That's going to cause vertigo. And it can also go and compress the facial nerve or damage the facial nerve, causing facial palsy. So all of these are the complications of this. So let's just review this and move on to the next one. So here let's move on and review it at the end. So let's go on to the next, which is called vertigo. Well, vertigo is a sensation of spinning while actually stationary. Simple thing, right? Subtype of dizziness, but distant from lightheadedness. Peripheral vertigo is more common than the central vertigo. So this is more common than central. So let's take a look at peripheral vertigo. Peripheral vertigo is due to inner ear pathology such as vestibular neuritis, benign paroxysmal positional vertigo, so BPPV, right? And that's the semicircular canal debris that causes episodic vertigo lasting less than 1 minute, provoked by certain head movements, diagnosed via Dick's Hallpike maneuver, treated via Epley maneuver, and Meniere's disease, which is endolymphatic hydrops. Again, you have endolymph hydrops is all about increased endolymph in the ear. And where was the endolymph? Well, endolymph was in the scala media, right? Scala media, which had the cochlear duct, right? And you can take actually, let's get you back here. This is the scala media, and it can, or also known as cochlear duct. It contains the endolymph. Okay, so here all we have is we have increased in the endolymph. Okay, this leads to three things. We'll try it, right? Vertigo, sensorineural hearing loss, tinnitus. So the mnemonic here is men wear vests. So vertigo, sensorineural hearing loss, and tinnitus. Findings are mixed, horizontal, torsional nystagmus. Horizontal. Just think about it, horizontal nystagmus, never purely torsional or vertical. Okay, that's important. Okay, so horizontal and torsional nystagmus, never purely torsional or vertical. That does not cause direction, and it is suppressible with visual fixation. So let's just review this whole peripheral vertigo. So peripheral vertigo is all about spinning while you're still stationary. You feel like you're spinning, sensation of spinning, right? So it is all due to inner ear pathologies, vestibular neuritis, and all that, right? So with BPPV, it's the semicircular canal debris. So you could these are the diagnosis part. You could diagnose it and treat it with some maneuvers. Basically, you're trying to get the debris out of that part, uh, and that debris is basically in the semicircular canals, and it causes episodic vertigo. Episodic vertigo lasting less than 1 minute, and provoked by certain head movements, because it's going to provoke that if that debris go into some place in the semicircle, and it's going to cause blockade, and that's going to cause vertigo. So you could diagnose it by Dick's Halpack maneuver, treat by Epley maneuver. The second disease in the peripheral vertigo. So first we talked about here. Second, this third is Meniere disease. This is all about increase in endolymph. That increased endolymph causes three things: vertigo, sensorineural hearing loss, and tinnitus. And findings are going to be mixed horizontal torsional nystagmus. Important. That would not change in direction, and it's suppressible with visual fixation. Okay. So that is what we have for the peripheral vertigo. Let's take a look at central vertigo. In the central vertigo, it's again, central means the brainstem, cerebellar lesions, stroke affecting the vestibular nuclei, demyelination diseases, or posterior fossa tumors. And that is again going to mess up your cerebellum, right? Findings are nystagmus of any direction. So basically, nystagmus that is not suppressible with visual fixation. If it is suppressible with visual fixation, you're going to think about Meniere's disease, right? And neurological findings are also there, like diplopia, ataxia, dysmetria. And these neurological findings are due to the fact that you are messing up your cerebellum. So this is going to be all for this one. Let's just quickly review this part from top. So here we talked about hearing loss, common causes, noise-induced hearing loss, presbycusis. Noise induces prolonged noise that's going to damage the organ of Cori by damaging the hair cells, damaging the cilia. So that when you have the damaged cilia, now you will not be able to produce any more sounds. It's going to affect, again, these two were high frequencies. They are both going to affect high frequencies because high sound, high age, causing high frequency loss. Okay. Presbycusis is all about aging. Okay. Age-related bilateral sensorineural hearing loss due to destruction of, again, the hair cell at the cochlear base only. You have destruction of the cochlear cell at the base. You could test the hearing loss by Weber's or Rainey test. Weber's is going to lateralize. Normally, it's just going to be both sides equal, no localization. But in the conductive, it's going to localize towards the affected ear. In sensorineural, it's going to localize to the unaffected ear. With the Rainey's, air conduction is going to be greater than the bone conduction, and that is called Rainey positive, which means it's normal. With the conductive hearing loss, all we have is bone conduction is more than the air conduction, and that we call it conduction problem, conductive hearing loss. With the sensorineural hearing loss is bilaterally, it's just decreased, but both, again, is total normal, which we see is AC greater than BC, which you see it here as well. So then you test with Rainey's to figure out if it is sensorineural hearing loss. Treatment was going to be there's a cochlear implant treatment, and that is going to stimulate the auditory nerve. Okay. Cholesteatoma is all about abnormal kernization in the middle of the ear. It could be congenital or acquired. Acquired has two causes. It's a primary and secondary. The primary is all about retraction of the tympanic membrane due to eustachian tube dysfunction. Secondary is rupture, infection, anything secondary. Trauma, surgery, anything can cause the secondary. And that is just that you have a migration, which leads to, first of all, perforation of the tympanic membrane, which causes migration of the squamous cells into the middle ear. It's going to present with painless otorrhea, but it can erode the ossicles, lead to conductive hearing loss. Whatever is in the ear we have is the mastoid ear cell. It can erode them, cause mastoid ear cells. It can erode into mastoiditis as well, and even erosion of the mastoid bone properly, prolonged long term. But also it can affect the cranial nerve 8 and cranial nerve 7, leading to facial palsies and all that. Then vertigo is all about spinning, right? Spinning when you're still stationary. It's a subtype of dizziness, but distinct from the lightheadedness. Peripheral is common than the central. And what are the causes for peripheral? Inner ear pathologies, for example, vestibular neuritis. If you recall, you have the unilateral, you have a unilateral vestibular neuritis, and you have a bilateral. So unilateral is it's also known as acoustic neuroma. Bilateral most commonly is due to schwannomas, right? Due to NF2. Okay, and then you have this the etiology is, and the next one is the benign paroxysmal positional vertigo, meaning, as the name suggests, you have a positional vertigo. In certain position, you're going to go into vertigo because there's a canal debris which goes and blocks the canal, right? So in certain position, you're going to go into it. So certain position will relieve that. So you have some maneuver that you can do, which is known as the exhale pike, which will diagnose that, okay, there is a problem, that there is a debris in the semicircular canal, and you can have a maneuver called Apley maneuver, which will treat this debris and remove that from that part, which was causing the problem, right? The second disease we talked about here is the mean ear disease. Here is all about mean ears, is the good mnemonic: men wear vest. Mean ears, men wear vest. V for vertigo, S for sensory neural hearing loss, and T for tinnitus. Okay, you can think about men's wear. I mean, this is just a mnemonic; it's not a real thing, but okay. Men's wear vest with increased sweating, right? Men wear vest with increased sweating. And why is increased sweating a matter here? Because we have increase in endolymph. So you're going to think about it. You're going to associate men's wear vest with increased sweating being Meniere's disease, that there is an increase in endolymph. And endolymph is where? Endolymph is in the scala media, in the cochlear duct, right? Which is also known as cochlear duct, right? And tried is very high yield. Now, importantly, what's going to happen is you have a nystagmus, horizontal torsional nystagmus, which is not going to be, it does not change the direction, and importantly, it is suppressible with visual fixation. Important. This nystagmus is going to be suppressible with visual fixation. With the central one, this nystagmus is going to cause nystagmus, but this will not be suppressible with visual fixation. And central basically means central, right? Central brain stem, cerebellar region. So when you have a cerebellar region, on top of nystagmus, you're going to get some other neurological findings of cerebellum, which is diplopia, ataxia, and dysmenorrhea. And that is going to be all for all otology ENT.